Assalamu alaikum. We will start our long clinical presentation day. We have Mr. Hamid, 65 years, with complaint of abnormal gait and recurrent fall. So we will start after the timer.
Yes. Hello.
Yes,
Yes,
wait,
hello.
please.
Yeah, I'm Dr. Ahmed, one of the medical clinic today. I'm spoke to the Mr. Hamid, 65 years old.
Yes, doctor.
Yeah, Mr. Hamid, we are here to take history from you and examine you and address your concern. Is that okay with you?
Okay, doctor.
Yeah. It came to my knowledge you are suffering from this abnormal gait and recurrent fall. Can you tell me more about that?
Yes, doctor. Actually, last 1 month, I don't know what happened with me. Like, I am not feeling okay. And when I'm walking, I feel that I some abnormal movement. Walking is not like previously. And I fall down. Actually, I'm like more prone to fall down. I don't know actually what happened with me.
Yeah, I'm sorry for what happened to you, Mr. Hamid. Which one is start first, abnormal gait or fall?
Yes, initially just started abnormal gait, and later I feel that I'm more prone to fall down.
Yeah. Can I know how do you, what do you mean by abnormal gait? Any,
Actually, I feel that abnormal gait means I feel it's not properly coordinated. My leg is going in the like that gap is increasing between my two legs.
yes. Yeah, I'm sorry for that. This is like, you mean like start by shuffling the, or small steps, then you can go?
No, I don't feel like that.
Yeah. Uh, do you need any support to go to make your walking, or you cannot?
Yes, yes, because sometimes I'm using walking aids, sometimes I'm another. My son is holding me to go washroom and other purpose.
Yeah. Along with that, do you have any abnormal movement of your hand?
No, I don't feel actually in my hand.
Yeah, both your hand is okay.
Yes, yes, so far it's okay.
Okay, since this is starting, it's increasing, decreasing, or the same, this abnormal gait.
No, I feel that it is increasing with more with time. Initially, it was little less, but now with time it's increasing.
Yeah, abnormal gait. Okay. Uh, do you notice any abnormal movement when you are rest or when you are walking?
No, I don't feel that normal movement.
Yeah. Okay. Yeah. Did you loss of consciousness at any time?
No, I don't feel low of consciousness.
Yeah. Do you have any headache?
Headache, yes, mild headache, not something serious.
Yeah. Where is the site of the headache?
Generalized,
Generalized headache. How is the severity of this headache?
it's like four like that.
Yeah. Do you notice anything increases headache?
No, I don't feel actually.
Yeah. Okay. Do you have any vision problem?
Yes, I feel there is a something blurring of my vision.
Yeah. Where is this start exactly?
No, it's actually long time. I feel it's like more than 2 years like that, 1 or 2 years like that.
Yeah, you have this vision problem more than 2 years.
Like that, 1 year, 2 year like that.
Did you sought any medical advice for this?
No, I went to doctor actually. They said maybe I have high blood pressure and diabetes. So they said maybe I need to control actually proper diabetes and blood pressure.
Yeah. Okay. Do you have any fits?
No, I don't have this.
Do you have any weakness anywhere in your body?
Yes, as I said you that I feel that abnormal movement, also some weakness like that
Where is the
in my
weakness
leg.
start? Where is the
in
weakness?
my leg, in my leg.
Both leg or one?
No, I feel both.
Yeah, both leg. Did you admit to the hospital for this any kind of?
No, I don't admit it in the hospital. Actually, I feel like that my hand and leg both are weak. But mainly, actually, leg I feel now more because when I'm moving, I feel more fall down. That's why I feel more in my leg.
Yeah, yeah, yeah. Yeah, I'm sorry for what happened to you. Okay. Did you have any skin change in your face?
No, doctor.
Okay. Uh, uh, do you have any history of high body temperature?
No, doctor.
Yeah. Any some kind of this chest pain?
No,
Any shortness of breath?
no,
Any cough?
no,
Okay. Do you have any tummy pain?
no,
Uh, did you have any tummy swelling?
no,
Any problem with your back passage?
no,
Any change in your color of your eyes?
no,
Did you have any weather preference?
no,
Okay. Uh, do you have any? You tell me no history of high body temperature.
no. You
Any
asked me
lump or
already, doctor.
yeah, any bump or any lumps or bumps in your body.
No.
What about your weight?
My weight is now 70 kilo. BMI like 24.
Okay. Do you have any difficulty of swallowing?
No.
Okay. Uh, any problem with your water work?
I feel actually it's like something uncontrolled, like not properly in my control. I don't know actually what happened.
Yeah. Again, uncontrolled.
Uncontrolled, yes. Sometimes I'm waking up.
Yeah. You lose يعني your water work.
Yes, yes, I lose my control.
Yeah. 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 Okay. Do you have any history of trauma to your head?
There's actually small trauma, like it's not something serious actually. It's maybe 1 year back. There's mild trauma in my head.
Where is this trauma? Can you tell me?
Yes, it's my back of the head. But it was
Back
okay
of.
that time. That time it was it's okay. It's not something anything serious.
Yeah, yeah. Did you sought any medical advice for this?
Yes, actually, doctor that time gave me the observation for the any red flag. And they don't found actually any red flag that time.
Any scan for your head that time?
Yes, that time it's not in that 1 year or 2 year that time. That time it's okay, that time.
He said, okay, huh? Yeah. Okay. Uh, with this recurrent fall, did you losing this is your water war control?
I don't understand what you said.
I mean, with recurrent fall, was this falling down?
Yes,
You
yes.
you lose you lose this your water war control?
Yes, there's the recurrent fall and water work control. It's almost the similar time actually.
Okay. Do you have any history of back pain?
Yes, doctor, I feel little back pain.
Yeah. Where is the site of the back pain?
It's my mid of the back.
Where? Yes.
Mid of the back.
Mid of the back. Yeah.
Yeah.
Also there is trauma to your back or no?
No, I don't get to now.
Yeah. Okay. Do you have any history of joint pain?
No,
Any skin rash?
no.
Any lower limb swelling?
Lower limb swelling? No, I don't feel swelling.
Any past medical history that should be aware other than this history of trauma?
Yes, doctor, as I said, I have diabetes, blood pressure, and high cholesterol.
Yes. I'm sorry for what happened to you. Are you on regular follow-up regarding this comorbidities, diabetes, hypertension, and cholesterol?
Yes, I'm following, but sometimes I'm losing my appointment actually. But most of the time I'm following.
Can I know the last reading of this hemoglobin A1C, this 3 months?
Like hemoglobin A1C, like 7. My blood pressure like 140 over 90. Now RBS is 8, like that. And
Yeah,
cholesterol is like borderline high.
did you receive any lipid lowering agent? I mean, any cholesterol management?
Yes, I'm taking long-time doctor statin.
Yes.
It's
Are you
little
compliant with
high.
this? Are
Yes,
you?
it's little high dose because it's not reducing my cholesterol by low dose. That time, doctor, it's make it high. I am taking all the medication I've taken almost like 10 years. But last 5 years, my cholesterol, like statin dose increasing because it's not well controlled, my cholesterol.
Yes. Do you have any family history of similar problem?
Yes, my father is also high blood pressure and diabetes.
Okay. Do you have any allergy to any medication?
No, doctor.
Do you have? I'm asking. Sorry for this question. Do you drink alcohol?
Yes, doctor, I'm okay.
How many units per week?
It's approximately 20 units.
Yes.
20 units.
Yeah, this is too much. I advise you to decrease this to recommended dose. And if you need help, I will refer you to the alcoholic association. Do you smoke?
No, doctor.
Okay. What do you do for a living?
I'm actually retired teacher.
Okay, can I examine you if you don't mind?
Okay, doctor.
Yeah, I will start neurological examination. I will start by the lower limb examination. I need
Okay.
firstly I will look for the observation for
Mhm.
any wasting, any vesiculation like this, any abnormal movement.
No abnormal movement, no circulation, no muscle wasting.
So what about the tone and power?
It's like tone and power, it's slightly low.
Yeah, hypotonia and hyporeflexia. Both lower limb, huh?
Mm. Yes.
Yeah, okay. Then I will do reflex in the
Yes, it's
uh,
also slightly low, not something serious. Slightly.
yeah, yeah. What about the sensation? A four modulus of sensation.
Yes. Sensation actually like touch sensation, pain sensation, I little reduced. Actually.
Loss.
Reduced, not 100% lost, reduced.
Where is reduced until where?
Like from foot to knee, like that,
Uh, Up to where?
up to knee.
Up to knee. Yeah, yeah. Okay, that is good. Uh, then I will go for examine the gait of the patient.
Yes, it's slightly broad-based gait.
Yeah. Okay, broad base gait. Where is the weakness specifically here? The weakness around the knee or around the side? Where is the power?
No, I feel
Power.
actually both the lower leg and thigh, both
Same.
sides, little weak actually.
Okay.
When I
Uh,
walking, I feel little weakness.
okay. What about the upper limb examination?
Upper limb examination is almost similar type.
Similar.
Almost similar type, yes.
2 minutes
Similar to
remaining.
lower. Similar to lower limb.
Yeah, yes. But it's not like I feel morely actually weakness in the leg, but upper limb not too much.
Yeah. Okay. Okay. What's your concern?
Yes, doctor. Actually, what happened with me? Please tell.
Yeah. I'm sorry for what happened to you. As you told me from this history, Mr. Hamid, most likely, to be honest with you, till now, you have a lot of condition we need to rule out. Firstly, uh, we thinking about what we call this peripheral neuropathy. This most likely may be related to the your uncontrolled diabetes or uh, taking a lot of drinking of alcohol. Also, this is problem may be related to your previous history of trauma. What we need now, what we need to do now, we need to admit you and do a scan for you and
Mhm.
involves a nerve doctor. Is that okay with you?
Okay, doctor. So it's need admission for me.
Just we need admission to do this kind of investigation and to control this because
Mhm.
you have recurrent fall and sometimes you have abnormal uncontrolled your water work.
Mhm. Okay, doctor. But what do you think? It's like cancer or something? Because I heard that if brain cancer happen, it happen also like that.
Uh, to be honest, we need to exclude the cancer. Maybe is the least of the possibility, but it seem not like cancer. But we need to rule out.
Okay, doctor. I think time finish, huh?
Yeah, time finished.
Yeah, yeah. Time is up. Let's go to the examiner question.
Okay. So, doctor, what's your finding and differential diagnosis here?
Yeah, actually, my finding this is 65 years old with recurrent fall and abnormal movement and recurrent fall. Uh, with history, he is no case of diabetes, uncontrolled diabetes, and uncontrolled hyperlipidemia. And he
Mhm.
has history of alcohol drinking. Uh, on examination, he has hypotonia and hyporeflexia, along with he has decreased reflex in the four modality. This most likely peripheral neuropathy may be related to the uncontrolled diabetes or may be related to the alcohol, chronic alcohol use. Along with that, we need to exclude uh, this
Mhm.
what we call history of trauma to the brain. He has previous attack of the trauma to his brain and back.
Back, I don't tell back trauma.
Huh? No, I mean to the
Uh,
brain.
yes. Okay.
I'm thinking, I'm thinking to be honest, of subdural hematoma at this age and a history of trauma.
Okay, but trauma got 1 year or 2 years back, but he's think of like 1 year, 1 month, 2 months.
Yeah, but sometime it can happen. Online.
Okay. So what's your differential here?
Firstly, I will put peripheral neuropathy.
Okay. And other?
Uh, uh, this peripheral neuropathy, secondary to diabetes or uncontrolled diabetes or alcohol.
Except the peripheral neuropathy, what other things? What you think other?
Uh, Also, I will put this kind of uh, I mean,
Okay. So what investigation you will do?
I will do MRI of the back and MRI of the brain. Also, I will do. Also, I need to exclude B. This is subacute combined degeneration with spinal cord.
Okay. But supposed to be subacute combined degeneration spastic. It will be like hypertonia, hyperreflexia, spasticity. The patient not tell you like that.
Yeah, yeah,
Okay.
yeah. Victor.
Okay. Anyway, how we manage this case?
Uh, Firstly, I will do this investigation, kind of investigation. I will do a scan of MRI of the brain and MRI of the back. Then I will do a blood investigation, including inflammatory marker, hemoglobin A1C, and lipid profile. Then I will control his diabetes, control his blood pressure, and control uh, leave it. Then I will involve the neurology department.
Mhm. How will
I
treat this
will,
case?
yes,
How will treat this case?
treat.
Treatment.
I will control. I will treat according to the cause. Yani. Also, I will advise the
Mhm.
patient to stop this alcohol.
Okay, okay. Okay. Thank you, doctor.
You are welcome.
Okay, I just tell you about some point. Yes, actually there is multiple issues here, but when patient tell you that there is a gait ataxia, with there is a urinary incontinence, and he's telling you wait up his urine. So what do you think in that issue? What is going to the diagnosis?
You mean Parkinson?
No, no, no.
How normal pressure
Parkinson's short,
hydrocephalus?
no, yes, you are right now, but are
But you
supposed to
didn't
be,
give me. I ask you a specific question. Do you have any
yeah,
abnormal movement of any one
no
of your
abnormal,
point of your hand? You didn't
no,
tell
no
me.
abnormal movement I don't have because there is a three features of the normal pressure hydrocephalus. There is
But
a
why?
gait ataxia, urinary incontinence, and also dementia. You also not ruled out about the dementia because there is a no abnormal movement supposed to be common in case of the normal pressure hydrocephalus. Abnormal movement like Parkinsonism, benign like cerebellar syndrome, also like
But
thyrotoxidosis, like drug induced.
but normal pressure hydrocephalus always will come with the patient with Parkinson.
No, I think not always come with the Parkinson because I have real patient. I don't found this patient with that Parkinson feature. Parkinson is different. Normal pressure hydrocephalus is different. Both
As I
pathology is
said,
different.
you go
In
missing with
the
the patient
if you normal
but
pressure hydrocephalus, typically if you are going, patient will tell you the ataxic gait, abnormal movement with urinary incontinence with dementia. These are the typical, and it's not like Parkinsonism. Parkinsonism is just different pathology. Parkinsonism not is always related with the normal pressure hydrocephalus, and it's no relation actually with Parkinsonism.
no, I
Totally
mean
different.
Parkinson plus normal pressure will come
No, no, no,
Parkinson
no.
plus.
Parkinson plus normal pressure hydrocephalus not under Parkinson plus. Under Parkinson plus, there is a five category: vascular, progressive supranuclear palsy, multiple systemic atrophy, Leo body dementia, and corticobasal degeneration. Normal pressure hydrocephalus it's completely different than Parkinsonism. And here actually you need to rule out about my memory, cognitive function, dementia, because it's neurological issues. So you have to rule out this. Actually, this patient, as I said you that long time back, 1 year, 2 years back, there is a one small head injury. At that time, it was CT scan normal. Yes, that is one of the factor. Maybe it's affect later, not maybe immediately affect. It's one of the factor. You already mentioned it about that thing. And regarding that patient is almost diabetic. I told you there's a diabetic and hypertensive, but you did not ask me about its duration. And I think also not ask which medication I'm taking for diabetes and hypertension. And another thing is I said you that I'm taking a statin for also long time and it's not controlled the statin. That's why doctor increased my statin level. So it's increased the statin level, one of the cause which can cause myositis. That's why actually my muscle become weak. That's why I feel weakness. So statin and steroid long time used it's statin and steroid causing that myositis, muscle weakness. So this is another issue for muscle weakness. That's why actually I'm feeling weakness to walking and more hand and leg. But as I'm using leg more during the walking, that's why I feel more weak in the leg. And also, I said you in my there is a back pain, and I said you yes, there is some pain I'm feeling sometimes like that. So we need to also rule out any osteomalacia, osteoporosis related with it or not. Because I told you also that I was retired teacher. Now I am retired and living at the home, so I have less exposure to the sun and other things. So this is one of the factors for developing the osteoporosis. And also, you need to ask me what about my food habit like calcium, rich food, sun exposure I'm taking and not properly. So it can cause osteomalacia, osteoporosis. It can cause this type of the weakness. And also, yes, you are right that diabetes, I have long-term diabetes. You asked me, and it's not 100% control, almost control, but not 100% control. So it can cause this type of the peripheral neuropathy. That's why sensation is lost for me. And I'm taking also alcohol. Alcohol also causes sensory neuropathy. So that is another issue. You already mentioned it. And actually, I said you my blurring of the vision, but you did not do any eye test like Snell's chart, then visual acuity and fundoscopy. You need to do fundoscopy because diabetes, hypertensive diabetic retinopathy may develop. That's why I have blurring of the vision. And you did my neurological examination, and I did also. I told you also about my what is the thing, vital sign. You missed to ruled out about my cognitive function, about my dementia, any hallucination or not. And you also missed that eye examination. Yes, you checked my heart lung sound. It was okay, and abdomen is also okay. Bowel passage okay, but I'm losing my control. I told you I'm waking up sometimes, and also I said you my back pain. So also better to check the back because if there is a back swelling, any scoliosis or not, because due to osteoporosis or osteomalacia, maybe there is some bone deformity can develop. And for that investigation, yes, need to do routine investigation, diabetes, hypertensive, investigation, cholesterol, HbA1c, fasting blood sugar, CBC, CRP, LFT, urine, and also you need to do that CT scan and then MRI to rule out that you need to involve the diabetologist and also specialist and neurologist, social support and for that medication, actually, like in the normal patient, hydrocephalus medication actually is not something effective. And you need to do also lumbar puncture because you need to check the CSF pressure. In the normal patient hydrocephalus, CSF pressure is supposed to be normal. And also in the medicine, actually, it's not beneficial if the acetazolamide given in case of the rest intracranial hypertension that or diuretics. But here actually have normal pressure, so medication actually not beneficial. But sometimes steroid can given to reduce the production of the CSF and like dexamethasone. And the main thing is actually ventriculoperitoneal shunting. And most of the patient actually well responding to the ventriculoperitoneal shunt. I think these are my comments. Thank you, Dr. Ali.
Yeah,
Yeah, thank you,
welcome.
Doctor. Thank you,
Your
Dr.
question
Tanvir,
is
for the case.
complicated.
Yeah, well done, Dr. Ali, by the way.
No
I will
problem.
give you, no, it's okay, we are learning from the mistakes.
Yeah,
And I will
yeah,
give
yeah.
you advice. In such case, you can put stroke, very liable to be in the differential. Cerebellar ataxia due to stroke. And all findings of cerebellar syndrome is there. I mean the ataxia, recurrent fall, hypotonia, hyperreflexia. So you can put it in the differential, and I think you can get the mark. Because normal pressure hypotenuse is little difficult differential. However, it's triad, and you have the triad in this patient, so it's okay. Good case from Dr. Tanvir, thank you, as usual. Weird cases, but it's interesting one. Thank you, Dr. Tanvir. So, commenting quickly, I think you didn't ask for the onset course duration, Dr. Ali, for how long? Any previous attack? The trauma, the trauma you asked, and the back trauma also, all this, but you didn't analyze the CNS full. I mean, for the mood and the memory, even the vision. However, you cover the headache and the awareness, consciousness, I mean, the weakness, the pins and needles sensation. So you cover all CNS apart from memory and mood. And in such age, you could ask about this. The hearing as well, you can ask the balance, and the balance here is the main problem. Other system review was quick, no finding. The cardiovascular, chest, GI, endocrine, genitourinary, and uncontrolled water walk here is due to normal pressure hydrocephalus. The joint and skin rash. Constitutional symptoms, yes, you ask also. Temperature, lumps and bumps, and weight change, appetite. You can add here also in such age the diet. How's your diet? Is it balanced diet? Because you can put differential for vitamin deficiency. Any vitamin deficiency can fit with this diagnosis. Ataxia due to vitamin deficiency, especially if the patient is vegetarian. Okay, the family travel history, medical history, yeah, a lot of finding in the medical history, hypertension, blood sugar, and control. You ask all this question good. And the follow-up, the lipid medication, the hemoglobin A1C, the allergy, the surgery, any admission. Then the social for the job, smoking and alcohol. But you miss the driving. It's very important in such case. Patient is having blurring of vision, as well as the analysis of the vision. You should ask and you should examine the eye in the examination. I will try to be talking in brief. The examination, you focus on the lower limb only. Uh, but instead you can do systemic examination from the hand going to the face and the eye. Eye very important in this patient. Eye field, eye vision, endoscopy, and reflexes. Pronator drift as well you can do quickly to rule out any stroke. Then the tone power reflex as you did, great, all the steps, the sensation, you cover all these examination steps. So for me, our differential in this patient, in the top normal pressure hydrocephalus, cerebellar ataxia due to stroke, either ischemic or hemorrhagic, and alcohol as alcohol or overdose or alcohol intoxication or side effects. It can lead to this kind of symptoms. Chronic subdural hematoma, I agree to put it because recurrent fall with old age, it might lead to chronic subdural hematoma, and the patient might present with this recurrent fall and drowsiness and some gaits change. Don't forget to offer for Romberg test. And the gait, patient already have a wide or broad-based gait as you explored. I think we cover all the topic, Dr. Tanvir. Any adding? Yes, abdominal associated, of course, because of alcohol and recurrent fall. Alcohol will lead to some change of conscious level, and he might fall, and the recurrent fall will lead to subdural hematoma, especially if the patient is taking aspirin for any heart attack or heart disease, ischemic heart disease. Yes, any comment for this case? Dr. Tanvir already covered the topic of normal pressure hydrocephalus regarding the investigation, the management, and occupational therapist is very important in the team for such kind of recurrent fall at home. He shouldn't be in second floor home or in home with or house with the stairs. He should be in first floor and the all his I mean the home will be arranged for to prevent any further fall. Okay, for the comment, let's read. Or before the comment, Dr. Ali, can you write the case for Dr. Tanvir in the chat box? It's normal pressure hydrocephalus. You need to ask about memory. Yes, sure. No relation with Parkinson. Parkinson is totally different. You will have tremors and bradykinesia, and the third triad of what is the third
دكتور
bradykinesia.
باسم بس
Yeah,
معلش
أهلين دكتور هند.
الله يسعدك يا رب.
طيب
Tremor,
remind us,
bradykinesia,
remind us.
and
Yeah,
tremor, bradykinesia, and rigidity. Cog will lead by rigidity.
yeah, rigidity. Yes,
Yes.
rigidity. Yes, this is the third. Yes, Dr. Hind. Yes, you can. Sorry, I
about
interrupt you.
just no, it's okay. Just about the gait يعني Dr. Ali when he mentioned Parkinson, I think he wanted to say something like not Parkinson, but the gait disturbance in NPH is similar to a great degree to Parkinson. I mean, it's like, it's not shuffling gait, they call it magnetic gait. It's a slow gait, but what mainly differentiate between the gait of NPH and the gait of Parkinson is the arm swing. And actually, those points has to be illustrated in the examination. So the patient should walk, and when he will walk, you have to comment on the character of the walking. I mean, it's a slow, and it's shuffling or magnetic gait, and the arm swing is normal. Turning is also slow, because usually those people, as I said, there is a common feature between Parkinson, which is the slowness, and but the arm swing is normal. So this is the only thing which is common between Parkinson and NPH, the character of the gait. But otherwise, when you examine for upper limb, or when you look for the cogwheel rigidity, for the bradykinesia, for the tremor, which is an important characteristic for Parkinson, you will not find it. Dementia is another common thing between both, but you need to have dementia late onset after the walking difficulty, rigidity, tremor in Parkinson. Usually it's after 5 years, but it's early onset in NPH. So this is the two difference between both of them. And not to mention that urinary incontinence is also an early feature in NPH, and it's a very late feature in Parkinson. So we cannot say that there is similarities except in the gait for us in such case. And we have to illustrate those differences by examining the gait and commenting on the arm swing. And also, when there is recurrent fall, we have to ask the patient if he sustained any injury. And if he sustained any injury, we should examine the site of the injury, whether there is head injury, any ecchymosis, any sequelae of this. And we have to inquire about the safety. And I think Dr. Bassem, he mentioned the occupational therapist, and there is even the fall clinic and some exercises done to minimize the fall. So those things has to be addressed as a part of the welfare. And also, once I saw a feedback for MPH, especially in male patients, because of the urinary incontinence. So you have to, make sure it's not related to PPH. I don't know if it is something very important, even though we don't usually discuss, but in that feedback, it was written that the candidate didn't offer a PR examination and didn't inquire about the symptom of PPH. Because usually whenever there is a elderly male and he have urinary incontinence, they just want you to touch the UTI symptom and the BBH. Okay, so don't forget to ask for urine analysis, urine dipstick, and offer PR examination and involving urologist. Okay. And so I still remember it. Really, I will never forget because it was written in the feedback. So in any case of MPPH, divide things. Urine incontinence, try to exclude the simple things. For the dementia and gait disturbance, try to exclude Parkinson. Okay, and other reversible causes of dementia. Before you say it's MPH. So you have to take every element of the triad alone. Otherwise, I think you discussed most of the issues. Just I wanted to add this.
Okay, thank you, Dr. Hind.
You are most welcome.
Always your comments are precious for us. Thank you. Okay, Dr. Tanvir, you ready? You have the case down?
Yes, I am ready. Just a minute. What is the name of the patient? 40 years old male. Okay, name.
I think it's Mr. John, yes. Okay.
Okay, I just listed that. Okay, you can start the time. Okay.
Yeah, here you go.
Okay. Hello, sir. I'm Dr. Ali, one of the doctors in the stomach clinic. Can I confirm you are Mr. John, 40 years old?
Yes, doctor.
Okay. So, Mr. John, I got a letter from your GP that you are suffering from tummy pain. Is it?
Yes, doctor.
Okay. Can you tell me more, please, about your tummy pain?
Yeah, doctor. I feeling this tummy pain since last 2 week, doctor.
Mm-hmm.
Increasing day by day.
Mm-hmm. I'm really sorry to hear that, Mr. John. So I will take some more history and maybe I will note something, but be sure it will be confidential and my full attention with you. And I'll do later some examination. Is it okay for you?
Yes, doctor.
Okay, so as you said, last 2 weeks, it's increasing the pain gradually. So can you tell me that actually which part of your tummy you feel pain?
Yeah, I feel here my right side, doctor. Mainly my right
Uh,
side.
right upper or lower?
Right upper.
Right upper side. So how much grading? You see, it's 0 is the lowest one and if 10 is the highest one.
9, doctor.
9. I'm really sorry. So do you feel every day this pain or it's coming and going and like that, or all the time it's present?
Most of the time present, doctor.
Okay, okay. So can you tell me that what type of the nature of this pain? I mean, heaviness, dull, or sharp? What type of the nature?
Dull pain, doctor.
Dull pain. Is it radiated anywhere from your right upper outside of the tummy? Anywhere it's radiated?
I think no, doctor.
Okay. So, do you feel any factor increasing this pain? I mean, when you are taking some food or medication, it's increasing. Is it like that?
I'm not sure, doctor.
Okay. Do you feel anything relieving factor? I mean, when you're not taking any food or any medicine, it can help.
No, doctor. No relation.
Okay, okay, I'm appreciating. So do you feel when with that pain there is a tummy fullness or distension?
Yes, doctor.
Okay. So do you feel that any type of the throwing up, I mean vomiting,
No, no, doctor. What do you mean by vomiting?
uh,
Sorry.
throwing up,
Yes. No, no, no throwing up.
not feeling of throwing up. So this type of the pain is first time or also you have previously this type of the pain.
No, doctor. First time I have this type of pain.
Okay, okay. So what about your bowel walk? I mean stool passing, it's okay.
Yeah, it's okay, doctor.
Do you feel over flatulence, like over gas passing something?
I'm not sure, doctor.
Okay. What about your water walk? Is it okay?
Yeah, it's okay.
Any changes in the amount, color, or frequency?
What do you mean? Sorry, doctor.
Any amount, color, frequency of your water walk?
It's okay, doctor.
Hello. Okay.
Yeah,
Uh,
it's
so,
okay.
okay. Okay. So, do you feel any type of the changes in your eyes, like I mean, yellow color or pale color? Somebody said like that.
Yes, doctor. Yes, yes. I look, my eyes become yellow, doctor. I know it's my brother. He tell me like this.
Mm-hmm. So, this yellow color, it's also for 2 weeks or also from previously?
Yeah, with the same period, doctor.
Same period. Okay. So, do you feel any type of the weight changes or the same weight?
No, doctor. Just for 2 weeks. I didn't. So
Okay. Okay. Any lump or bump changes in your body?
no, doctor.
Okay. And okay, so I just want to ask some other more question. So do you feel any type of the pigmentation develop in your body with that? I mean, any discoloration, pigmentation?
No, doctor. I didn't observe.
Okay. Do you feel any type of the joint pain?
No, doctor.
Okay. Do you feel any headache or dizziness?
I'm not sure, doctor. No headache. No, no, no.
Okay. Any loss of the weakness? I mean, any weakness or sensory changes in your body?
No, doctor.
Okay. What about your swallowing? I mean, swallowing. Okay.
Where is swelling?
Swallowing, swallowing. When you're taking
Very.
food, you can swallow,
Yeah,
swallow.
my swallowing is okay.
Okay. And is there any problem with your speech?
No, doctor, it's okay.
Okay. Do you feel any type of the hot or cold temperature preference?
No, no, doctor.
Okay. So what about your chest? Is there any chest pain,
No, doctor.
any coughing,
No, doctor.
any heart racing or beating,
No, doctor.
any type of the heartburn?
No, no.
Okay. So I just want to know some other things. Do you feel any type of the blood passing through your mouth or through your stool or urine?
No, doctor, but I feel early morning my urine is not okay.
Not working is what?
I'm not sure, doctor. My color is not okay. It's not
It's
like
is it
cola.
red color? It's like cola.
Yeah.
Okay, 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 okay. Okay. So I just want to know actually, do you have any long-standing disease condition like diabetes, hypertension, or long-standing tummy problem?
Doctor, you asked me many questions. I don't know. I get it. I didn't get your
I
point.
mean, any long-standing disease, as an example, like diabetes, high blood pressure, any long-standing disease.
No, doctor. I have diabetes.
Okay. Are you taking any medicine for diabetes?
No, doctor. Just this is. I think we doing this last this 3 months hemoglobin A1C. I guess I found six. Doctor
Okay.
advised me just for this
Mhm.
what to do just lifestyle.
Okay, okay, okay. It's appreciated. Okay. Are you taking any other medication, any type of the medication regularly?
No, doctor.
Okay. Is this similar or any other long-standing disease running in your family?
No, doctor. No, I didn't.
Okay. So what you're doing for living?
I'm driver, doctor.
Okay. How much it's affected your driving?
Yeah, doctor. Since 2 weeks, I didn't go for anywhere just because I'm suffering from this issue.
Okay, okay. I'm really sorry for that. We can involve that occupational health worker, and I just want to advise you if you feel more tummy pain and it's causing disturbing your driving, so better to stop your driving. Is it okay?
Again, doctor. Sorry, I didn't get your point.
I just tell that we can involve that occupational and social worker. They can help you. And if this type of the pain is causing impairment of your driving, so better to stop your driving the plan. It's okay for
Oh,
you?
yeah. Okay. Thank you, doctor.
Okay, welcome. So I just want to ask some personal question if you don't mind. Do you smoke?
Yes, doctor.
How much? How many cigarettes? How many years?
10 cigarette over 10 last year.
Okay, I just want to advise you to stop the smoke because smoke any amount is injurious for health for any issue. And if you want, we can send you to the smoking cessation clinic.
Yeah. Okay.
And do you take alcohol?
Yeah, doctor. I drink alcohol
How
actually.
much
Actually, I drink 10 unit every 4 days.
every 4 days? Okay, it's actually crossing the upper limit. So I just want to advise you reduce your alcohol intake. It's better to reduce it 14 unit, less than 14 unit per week. Is it okay for you?
Yeah. Okay.
Okay, I just want to know that do you traveling anywhere recently?
No, doctor.
Okay. Do you have any contact with sick person?
Sorry, doctor.
Do you have any contact with any type of the sick
No, no,
person
no, doctor.
recently?
No, 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 no.
Okay. So I just want to know the another thing that what you feel. What about your mood? Do you feel any type of the mood changes or any type
No,
of
no, doctor.
the depression, anxiety, something?
My mood
Okay,
is
okay,
okay.
okay, okay. Thank you. So I just need to start examination. Is it okay for you?
Yeah, please, doctor.
Okay. So first of all, what about the vital sign? Blood pressure, temperature, respiratory rate.
Blood pressure 120 over 80. Pulse
Mm.
80 beat per minute regular. Synchronous.
Mm.
Yeah.
Temperature,
Temperature
RBS,
37.
RBS,
RBS is okay. Is 6 millimole.
Okay. BMI, it's normal BMI,
BMI of the patient is 26.
26. Okay. So I just need to check the hand. Is there any of the hand like any jaundice, pulmonary, leukocyte, clubbing,
Normal in hand examination.
any palmar erythema, dependence contracture?
Normal. No any
What
stigmata
about
of
the
coronary hemorrhage.
any flapping tremor?
No.
Okay. Any skin changes? I mean, there is a tattoo mark, needle mark.
No.
Okay. What about is there any weakness in the, I mean, proximal myopathy something?
No.
Okay. What about its eyes, any jaundice or anemia? As you said, there is a jaundice.
Yeah,
Is
is a little bit yellow.
jaundice, okay. Yellow. Any anemia?
No.
Okay. What about the mouth? Is there any mouth ulceration, dehydration, gum hypertrophy?
No, it's okay.
Okay. Any swelling in the neck?
No.
What about your vision? Do you have any problem with visual difficulty?
No, doctor.
Do you feel any type of the raised body temperature?
No.
Okay. I just need to auscultate lung. Is there any other sound in the lung?
No, doctor.
Any abnormal heart sound?
Normal.
Okay. I just need to examination your tummy. If you feel any pain or discomfort, let me know.
Yeah.
So is there any like superficial tenderness to any part? As you said, only right hypochondrium, but any other part?
No.
Okay. What about the liver? Is it enlarged liver?
Yes, liver is large. 10
How many
centimeters below
centimeters?
the colon.
What about its surface and consistency? Surface normal, consistency normal.
Yes, normal, consistent, above standard.
Okay. Any surface irregularity or something?
No.
Okay. What about other organ like splenomegaly or enlarged kidney?
Normal.
Okay. Is there any ascites?
Yeah.
Okay. So I need to do shifting dullness. I
How
need
to
to do
do?
shifting. I need to do shifting dullness. I'm doing percussion from and I'm going to the left side. Then I need to. I was supposed to be. I'll get the dull. I just rolled out and wait for 30
Positive.
seconds.
Positive.
Okay.
Positive
Okay.
shifting
Shifting
normal.
dullness. Okay. Switching also. I think positive also. Okay. What about its bow sound? Bow sound normal.
Yes, normal also.
Okay. Then I need to say any leg edema.
No, no.
2 minutes
Mine,
remaining.
no,
No. No.
mild
No leg
only.
edema. Mild leg edema. Okay, I just want to ask you some other history. That is there any blood-related disorder in your family? Blood-related issue?
No, doctor.
Okay. Are you taking any blood thinner or something?
Before, yes, but no, I didn't took anything.
Okay, now you're not taking. Okay. As I want to ask you, do you sharing any needle? If you don't mind sharing any needle or any drug to your blood channel?
No, doctor.
Okay. Okay, thank you. So I just want to know that what's your concern?
Yeah, probably. Doctor, what's wrong with me?
Actually, so from your history and from your examination, what I'm thinking that is actually problem with your liver disease. That's why actually it's become enlarged in size. You feel pain, and also I found there is some fluid accumulation in your liver. It's probably it can due to your long time taking alcohol and it's over the limit. This is one of the issue, and also there is something color changes of your urine, so it can be some blood related issues, but we need to do some blood investigation, your fluid examination of your tummy,
Doctor, is the
and also
cancer?
we need. Yes, actually, it's a cancer is actually less likely because as you are young in the age, you don't have that weight loss. Very less likely it's cancer. It's probably due to the your some liver disease. but we can confirm it by doing that imaging of your tummy, blood test, and your fluid examination of your tummy. Do you have any other concern? And later we will involve some bowel doctor, physician nurse, according to the finding and your
Yeah.
diagnosis.
Okay, doctor.
Okay, thank you.
Okay,
Yeah,
time is
doctor.
up. Examiner time.
Yes. Can you please tell me what do you know? What about what you got it from history and
Actually,
examination? And what's your
actually
differential
this,
diagnosis? What's your
okay,
differential
actually this,
diagnosis?
yes,
And
actually
keep it
this 40
question.
year, okay. Actually, this 40 years male, Mr. John, coming with there is a abdominal pain, and this pain mainly in the right hypochondrial area. And also on examination, I found there is a enlarged kidney centimeters on the coastal margin, and there is a tenderness. Also, there is the ascites and mild leg edema also developed there, and he has the history of the alcohol intake, but no history of the like fever or like not symptomatic for infection. And so, according to the from his history and from the examination finding, what I'm thinking, this is maybe probably alcoholic liver disease by one of the differential diagnoses. Second differential diagnosis can be that hepatic vein thrombosis, and there is a pain. And also, my another differential is as there is a cola colored urine, it can be happen due to the venous thrombosis. And another differential can be that acute intermittent porphyria, but against that, there is a no neurological cognitive function impairment,
What do
no
what do
mood
you mean by
disturbance.
hepatic vein thrombosis?
Sorry.
What do you mean by hepatic vein thrombosis?
Actually, as there is a liver tenderness and also there is a urine color change, it's maybe there is a hepatic vein thrombosis can happen, but again, there is a no history of the like the blood disorder, but he's taking some blood thinner medication previously. Maybe now he has stopped that medication. That's why now vein become thrombosed. Maybe
What is the
that's
term?
another issue.
What's the term to describe this condition?
Budd-Chiari syndrome.
Yeah, about Chiari syndrome. Why you said but Chiari syndrome?
Actually, as patient said that he is taking before some blood thinning medication, now not
Other
taking.
uh,
So
uh,
this is
uh,
one of
uh,
the issue.
did you ask
And,
about the previous history of hospitalization?
no, I don't ask actually. Yes,
Yeah.
this
Other
is one
thing,
of the points.
yes. Other thing, why you think about Batchiari other than this blood thinner medication?
Actually, I'm thinking because there is it's a one of the issue where there is a liver become tender. This is one of the issue. Like we need to rule out what are the reason of the tenderness. So my one of the issue is
What is the
alcoholic liver
clue? I
disease.
mean, so what is the clue in the history? What's the clue in the history?
From the history, there is a tender liver which is favoring for the Budd-Chiari syndrome, and he is
This is
taking before something blood thinner. That is the another favorable point. Maybe he has some undiagnosed or diagnosed coagulation disorder. That's why he's taking before blood thinner. And
other
another
than
issue
this.
is yes, another issue patient now develop ascites. So this is another issue. This is one of the feature of liver impairment and hepatic
Other
vein
than this.
thrombosis.
Other than this.
Other than this, I don't think any other point for supporting Budd-Chiari syndrome because it can be also causes the infective issue, but he has no
The
feature of
patient,
the
he said what is the color of urine of this patient?
is cola colored. He said that cola colored. That's why I told you that we need to rule out also acute intermittent porphyria. But against there is a no mood disorder, no cognitive function impairment. That is the
No.
against the point of the acute intermittent porphyria.
Cola color in the morning. What this indicate? And this patient has
Cola
TB.
color. Sorry.
Yes, cola color in the morning, and the patient has
And it
previous
can be
history of.
like paroxysmal nocturnal hemoglobinuria. This is
Yeah,
another issue.
definitely. Yes. What is the other differential diagnosis you need to exclude other than Bechiari syndrome and chronic hepatitis? Other differential diagnosis?
Other differential diagnosis here, actually, like it can be that non-alcoholic fatty liver disease because he has that metabolic syndrome as 29, I think BMI said 29, also diabetic. So also it can cause this fatty liver disease. That is another issue for liver tenderness.
Other than this, what's the concern of the
Uh,
patient?
Other than he's asking actually for that carcinoma, but carcinoma is very less likely as young age, no history of the weight loss, and no lumping, bumping, and only there is a yellowish coloration in the eye, no changes in the hand. That's why I'm not thinking it's the carcinoma. It's a least possibility.
Other cause of tender liver?
Tender liver actually can causes for lots of the issues. Right? First of all, alcoholic liver disease, Budd-Chiari syndrome, even carcinoma, and even liver abscess. It
Yes, a
can
liver
cause it.
abscess.
Yes,
We need to
but here
exclude the
actually liver
congestive heart
abscess,
failure or
yes.
no? We need to exclude congestive
Yes,
heart failure.
congestive heart failure is need to exclude, and that's why I checked that auscultation. I don't found any chest scale, any added sound, but there is a small point. There is a very mild pitting edema. This is the one of the point, but the chest is clear. That's why I'm not thinking it's a congestive cardiac failure.
Yeah, you need to mention this tender liver.
Yes, yes, of
Yeah,
course, of
your
course.
time now is off. Just I'm asking, what do you do? What investigation you need to do in this patient? Please
Actually, first
specific.
of all, if it's specific, we need to go for first as there is ascites, we need to go ascitic fluid draining, and we need to send for cytology, microscopy, culture sensitivity, and acid flux bacilli, and also serum ascites, albumin gradient. We need to check to rule
Specific,
out if
specific,
and
doctor.
I'm telling you some point that first of all, acidic fluid examination we need, and also we need to do that ultrasonography, and we need to do hepatic
Which
serology.
kind
And
of ultrasonography? Which one?
sorry,
Which
what?
one? Which
I'm telling some
ultrasonography?
ultrasonography, Doppler ultrasonography
Yes,
of the hepatic
Doubler,
vein.
Doubler, Doubler, Doubler.
Yes.
I asked you a specific Doubler.
Doppler ultrasound, yes. Because actually there is
Okay.
some issue. We need to rule out actually some specific thing, like I think full liver issue we need to
Mm.
rule out. Like Doppler ultrasound, as there is ascites, first of all, we need to rule out acidic fluid draining and all the things, cytology, microscopy, culture sensitivity, AFB, and acidic fluid albumin gradient. We need to do ultrasonography, Doppler ultrasonography of the hepatic vein. We need to do
Dr.
even
Tanvir.
CT scan to rule out
How
any
you manage this
carcinoma.
patient, doctor? How you manage this patient?
Okay, and also I need to do basic blood test, all the things, and I need to manage this patient first of all, non-pharmacological. We need to stop the reduce the alcohol intake below the social limit. We need to involve the gastroenterologist, special nurse,
We need to
social
admit this
support.
patient or no, doctor?
In that case, actually, we need to admit the patient because there is a chance of the bacterial syndrome, hepatic vein thrombosis. We need to give anticoagulation, injectable anticoagulation like low molecular weight heparin for 5 days, and later we can give some oral anticoagulant. And also, we need to, if there is the ascites is too much, huge and large ascites, and it's discomfort causes, we need to drain the ascites fluid.
Okay,
And
thank you, doctor. Okay,
sorry,
thank you, doctor.
Okay.
Dr. Tanvir, I will give you some advice. You are very good, very, very good. But the problem of you, you need to, you explain more. You took your time by yourself. When I ask you what's your differential diagnosis, please go direct for differential diagnosis. No need to explain more and more. This will take your time. No time in the
Mhm.
exam, no time. Even if your examiner you ask you, just he will listen to you. Not just when I ask you, tell me I need to exclude one of the first possibility, but Chiari syndrome I need to exclude. As a patient history of blah blah blah. Also, I need to exclude on the view of the tender liver. I need to exclude acute viral hepatitis. Also, I need to exclude amoebic liver abscess, for example. Also, I need to exclude the right heart failure and HCC, hepatocellular carcinoma, of the view of the history of the tender liver, like this. But no need to talk more. Even investigation, I ask you direct question, which is specific. Just tell me. Apart from blood investigation, liver function test and liver enzyme analysis, I will do Doppler ultrasound. No need to talk more. If you talk more, you will lose your time, and the examiner will not
But
help
here
you.
actually, if there is the ascites, this is very
Yes.
important. Acidic fluid tapping. If we
Yes.
without we if I'm not telling this thing, it will be big mistake.
No. Just comment. Just a general comment. Yes, we need to. So we need to do this acidic tab. We need to liver function test. Even we need to do a CBC. Even we need to diagnose the patient why
No,
he has
CBC is
developed this
okay.
Berkshire syndrome.
CBC is
We
we
need to
can tell
search for the
later.
cause. We need to search
Yes,
for
yes.
the cause. Even we
Like
need to search for
aesthetic
the
tab,
cause.
liver function test,
But when
and
I ask your
Doppler
differential,
ultrasound. This is
just
important. Yes,
go direct for differential.
yes,
Your
yes,
history is targeting, but you forget to ask what is the previous history of hospitalization. If you ask me, I tell you I
yes,
will
yes, yes.
admitted 6 months back for
Mm-hmm.
DVT in my lower limb, and
Ah,
you
okay,
give
okay.
me 3 months. This actually this cases, but Chiari syndrome, the risk factor is
Uh-huh.
secondary to the uh,
DVT.
paroxysmal nocturnal hemoglobinuria. Sometimes we can present with the secondary to the Behcet syndrome, or sometimes can even
Mm-hmm.
thrombocythemia.
Any hypercoagulative state like
even
polycythemia
even
rubra
in
vera,
female
essential thrombocytosis.
in sometime in female can be present secondary to the recurrent
OCP,
abortion. Yes.
Apla syndrome,
Okay. Or
OCP.
OCB. Or OCB.
Yes, yes, yes,
Antiphospholipid syndrome, I mean.
yes,
This is
yes,
a very common case in exam.
very common. Yes, yes,
Yeah.
exactly.
This is all my comment. Just I advise you and even myself يعني, just when you
Yes,
ask
yes,
about
yes,
the differential to be targeting يعني, not to talk more
yes,
more
yes,
more.
yes,
If you
yes.
talk more you will lose your time even in the history.
Mhm. Okay.
Other than that, you ask about all, يعني you ask about travel history, this will exclude the hepatitis. You ask about history of fever, also exclude hepatitis. And you ask, lastly, you ask about the history of extramarital relationship, and you didn't ask about history of blood transfusion. This is the most important. Yeah, we need to exclude also.
Yes, I asked about that IV blood, anything taking IV drug, but not asked about the blood transfusion. Yes.
Yeah. This is my all comment.
Thank you,
Dr.
doctor. Thank you.
Basil,
Thank you for adding the
welcome.
points.
Okay, thank you, Dr. Ali, for the case. Well done, Dr. Tanvi. Actually, you reached diagnosis while giving the differential, but still your differential were valid for the case. As you mentioned, alcoholic steatohepatitis can be one of the differential. Viral hepatitis also can be. Congestive heart failure as well is valid. But the case here, due to the finding of early morning hemoglobinuria, so it's paroxysmal nocturnal hemoglobinuria complicated by Budd-Chiari syndrome. I think the case was straightforward when he mentioned the genitourinary symptoms or signs. But I advise you, Dr. Tanvir, to ask questions separate. You ask for the genitourinary three questions at the same time. And change the frequency, color, and amount. And he might answer you one, the last word, the last question, and he might not answer you. So be specific in this kind of question. So that's why he didn't give you the positive finding of early morning change of the color. I think so. And I hope also the candidate who can give the case next time to help the surrogate, sorry, to help the candidate. If any change, he can mention from the first question. Because you volunteer give the answer, Dr. Ali, later, but he asked you earlier. I think in the exam they will give him the from the first question. Okay. I think for the comment, Dr. Tanvir were systematic from the beginning, onset course duration, the site and the radiation. You can ask where the pain goes. The radiation is jargon, so you can ask
Yes,
where the pain
I
goes.
asked, is it radiated to anywhere? I asked it.
Yeah, yeah, radiation is, I mean, jargon.
Yes, yes.
Yeah, so you can ask where the pain goes or travel. So this is the way in how to ask without jargon, where the pain goes or travel. The nature, the timing, what decrease, what improve, or what improve, and what worse. Is it related to the food, the scale? all this question relevant, and the GI system also relevant, throwing up, difficult swallowing, feeling full in the tummy, and change the back passage. And in this patient, particularly, you can ask about any blood in the stool or any dark stool, because you have a hepatic patient. He might be chronic liver disease, and you will miss the melena. Along with the medication, as you said, any blood thinner medication. Then other system review was or were irrelevant because this patient is mainly gastro or gastric system affection, along with genitourinary, but also you can ask any previous clot for the hematology or for the blood. Skin and joint pain, just in case of affection, but in this case it wasn't. Constitutional symptom, you ask the family history important in this patient because it's I think it's inherited one, familiar. Travel history important as well for the acute hepatitis A especially. And in this patient, I think the onset of 2 weeks can fit the case as acute hepatitis A. Medical history for diabetes, contact with sick patient, the HIV very important in this patient, and along with other question for hepatitis, sharing needles or blood transfusion, as well as any casual relationships. Okay, then the examination, I think it will be target to the GI, the hepatic to the liver, and as we noticed, the spleen is not enlarged, and this is explain the condition, which is Budd-Chiari, because only the liver will be enlarged and tender, along with ascites. I think the differential, yes, we can repeat the differential. Budd-Chiari syndrome, alcoholic steatohepatitis, and viral hepatitis. The last differential could be congestive heart failure. But against that, no heart affection or no cardiac symptoms. Okay. Any question, any comment?
Yeah. Regarding this differential, we need to alcoholic steatohepatitis will not cause tender liver. Usually, or not will cause fatty liver, not tender liver.
Yes,
usually
and it will
you
be chronic. Yes, you're right. Yes, you can.
yeah,
Yeah, you can.
yeah. You need to set Budd-Chiari syndrome on the top. Second thing, we need to say uh, alcoholic hepatitis. Patient has drinking every 4 days 10 means the 1 week more than 20. This is alcoholic hepatitis. Also alcoholic hepatitis, one of the cause of the tender liver. Ischemic hepatitis you can set, or acute viral hepatitis also.
Yeah.
Amoebic liver abscess or any liver kind of biogenic or amoebic can cause.
Yes.
HCC can cause, but against HCC,
No BE
we
symptoms.
need to put even we need to put in the differential, but is the least on the bottom. Also congestive heart failure can cause this tender liver. Usually this
Yes.
case came in the exam to ask you about the differential diagnosis of the tender liver.
Yes. Yeah, thank you, Dr. Ali, for the case. Any other question?
السلام
Any
عليكم.
comment? وعليكم السلام ورحمة الله وبركاته.
باسم كيفك تمام؟
أهلين الحمد لله.
I think I have theory, I think, regarding to this case, because now we have Budd-Chiari syndrome secondary to paroxysmal nocturnal hemoglobinuria. So if in investigation, if we said that we need to do investigation to confirm paroxysmal nocturnal hemoglobinuria, like CBC, in order to see pancytopenia and LDH and flow cytometry, CD 55, CD 59, and peripheral blood picture, and investigation to confirm Budd-Chiari syndrome per se, like ultrasound Doppler. because the management it depend on this one. Because now we have patient with paroxysmal nocturnal hemoglobinuria and develop Budd-Chiari syndrome. So the treatment will be treatment of both, not only Budd-Chiari syndrome. So we'll give,
Yes, exactly.
if there is anemia, we'll give blood transfusion, we'll give iron supplementation, and we'll give ocrelizumab, and even may need bone marrow transplantation in some stage. And regarding to the clotting, we will give anticoagulation and like warfarin
Yeah.
and anticoagulation. Is that okay?
Yes. Yes, sure. And you can involve also hematologists for such cases.
Exactly.
Hematologists, multidisciplinary team, hematologists, along with hepatology, gastroenterologist. So hematology and gastroenterology. Okay, thank you, Dr. Tawfiq.
Allah
Yes,
يخليك.
add to this investigation genetic testing for paroxysmal nocturnal hemoglobinuria to confirm diagnosis. Okay, any other comment? Thank you, Dr. Tawfiq again. Any other comment, any question, any inquiry? Okay, thank you, Dr. Tanvir and Dr. Ali, for the case today. Very interesting cases and new topic. Hopefully, we'll meet in the next week. If no question, we have a nice weekend. See you after tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.